Welcome to my channel. Today I'm gonna read about orbital cellulitis with you guys. You want to read with me, and if you don't want to be alone while reading for exam preparation for exam, then this channel is for you. So orbital cellulitis in intraorbital abscess. I'm gonna read about orbital cellulitis. Orbital cellulitis refers to acute infection of the soft tissue of the orbit behind the orbital septum. Infection of soft tissue of the orbit behind orbital septum. Orbital cellulitis may or may not progress to subperiosteal abscess or orbital abscess. So mode of infection everywhere. If you ever don't know the mode of infection, you can write for exogenous, endogenous, secondary to the infections like from neighbor, like chronic dacrocystitis, like that. See, paranasal sinus, teeth, face, leads, intracranial cavity, wherever the neighboring structures are infected, then it will come to the orbit. Exogenous infection from penetrating, especially when associated with retention intraorbital foreign body following operation with evisceration, enucleation. Um, Whatever it come from outside, okay, penetrating injuries. Um, Followed by operations like evisceration, enucleation, dacrocystectomy, orbitectomy. Endogenous, it may rarely develop as metastatic infection from breast abscess, puerperal sepsis, thrombophlebitis of legs, and septicemia. Okay, and causative organism. Those commonly involved are Streptococcus pneumococcus, Staphylococcus aureus, Streptococcus pyogenes, Haemophilus influenza. Again, these are like most common bacteria that are that causes infection to the eyes. Streptococcus pneumus, Streptococcus pneumonia, Streptococcus aureus, pyogenes, Staphylococcus aureus, Haemophilus influenza. Pathology. Pathological features of orbital cellulitis are similar to suppurative inflammation of the body in general. Infection establishes early due to absence of lymphatic in the orbit. Okay. Rapid spread with extensive necrosis is common since it is in most cases infection spread as thrombophlebitis from surrounding structures. Okay. Damage produced is rapid and extensive as the orbital infection is associated with intraorbital pressure due to tight compartment. Yeah. Okay. Extensive necrosis infection establishes early. Okay. Mhm. Absence of lymphatics, infection spreads early. uh, Extensive necrosis present as infection spreads as thrombophlebitis manner, and the damage is produced rapid, extensive as the orbital infection is associated with the orbital pressure, intraorbital pressure to tight compartment. Clinical features: swelling and severe pain or main symptoms. Okay. Associated general symptoms like systemic symptoms like fever, nausea, vomiting, prostrations, or you can see vision loss with diplopia can be complained by patient with moderate to advanced diseases. What are the signs of orbital cellulitis? Okay, you can see here orbital cellulitis in a 3-year-old female child. We can see swelling of the lid characterized by woody hardness and redness is usually marked. Yeah, redness we can see, woody hard swelling is there. Chemosis of conjunctiva may protrude become desiccated or necrotic. Axial proptosis of varying degree is present. Restriction of ocular movements, RAPD due to complication of involving of optic nerve. Fundus examination may show congestion of retinal veins and sign of papillitis or papilledema. Okay. Congestion of retinal veins and signs of papillitis or papilledema. Yeah, we can see papilledema and optic nerve damage and ocular movements, axial proptosis, chemosis of conjunctiva, swelling of the lid. Complication. These are quite common if not treated promptly. Ocular complication, orbital complications, orbital. In ocular complication, we can see vision loss, include exposure keratopathy, optic neuritis, central retinal artery occlusion. Because of pressure, um, there is neuritis, and on artery we can see occlusion, exposure keratopathy, These all cause vision loss. And orbital complications, abscess, subperiosteal abscess, collection of purulent material between orbital bone wall and the periosteum. Um, Most often located along the medial orbital wall. This is the medial side. Here will be the orbital. Here the abscess will form. Most frequently along with medial orbital wall. Clinically, subperiosteal abscess is suspected when clinical features of orbital cellulitis associated with eccentric proptosis, and the diagnosis is confirmed by CT. Orbital abscess is collection of pus within the orbital soft tissue. Clinically, it is suspected by signs of severe proptosis, marked chemosis, complete ophthalmoplegia, plus points below the conjunctiva, pus points below the conjunctiva, confirmed by CT. Temporal parotid abscess may occur due to spread of infection around the orbit. Intracranial complications include cavernous sinus thrombosis, meningitis, brain abscess, etc. General septicemia, pyonia may occur eventually in few cases. Investigation: bacterial culture should be performed from the nasal and conjunctival swabs and blood sample. Complete hemogram may reveal leukocytes. X-ray of paranasal sinus to identify associated sinusitis. We have to do whatever we can. Culturing, complete blood picture and X-rays of paranasal sinuses and orbital USG to detect intraorbital abscess, and CT and MRI to differentiate preseptal and postseptal cellulitis, to detect subperiosteal abscess, orbital abscess, detecting intracranial extension, in deciding when and from where to drain orbital abscess. Orbital cellulitis is an Orbital cellulitis is an emergency, so the patient should be hospitalized for aggressive management. Intensive antibiotic therapy. For staphylococcal infection, high doses of penicillinase resistance antibiotic combined with ampicillin should be given. Ceftoxam, all cephalosporins or methicillin resistance, we can give vancomycin. If they are penicillin resistant, yeah, we can give antibiotics like that. To cover H influenza, chloramaphenicol, clavinic acid should be added. To cover anaerobics, oral metronidazole 500 milligrams every 8 hours. So yeah, and in antibiotic therapies, use penicillin against staphylococcus infection. Use cephalosporins. Alternate to penicillins, and for anaerobics we have to use metronidazole. For H influenza we have to use chloramaphenicol or clavinic acid. Analgesics are anti-inflammatory or helpful in controlling pain, and analgesic and NSAIDs. And topical antibiotic eye ointments we can also give. Nasal decongestion should be started. Reevaluation as twice to thrice daily in hospital require monitored response, modify the treatment accordingly. Surgical intervention, it indicates include unresponsiveness to the antibiotic, decrease in vision, presence of orbital abscess, whatever that. If not prognosis is present, then we have to do surgical intervention. Immediate canthectomy, cantholysis may be needed. If the orbital is tight, we have to decompress the orbit pressure compartment. Free incision to the abscess to get extraction of the abscess. Draining, and subperiosteal abscess is drained by 2 to 3 centimeter curved incision in the upper medial aspect. In most cases, it is necessary to drain both the orbit as well as the infected paranasal sinuses. And yeah, that's it.